pigment epithelium. It is bordered anteriorly by the vitreous and then posteriorly by the choroid. And then external and posterior to the choroid are the external and posterior to the retina at the choroid. So this is just a diagram that is just trying to explain what I just said there. You have the cross section of the globe there, and we can see the sclera. That's the sclera there. You have the choroid, the RPE, retinal pigment epithelium, and then you have the retina, and this is your vitreous in there. So this is also the same cross section of an eye with a detached retina. So we have a retinal tear there, and then a cross section of it is taken out to show what actually happens between the RPE there and then the neurosensory retina. There's a space there. This actually is obstructing I can't see because of I don't know if I should minimize that. Okay, so we have fluid collecting in the neurosensory, the subretinal space between the RPE and then the neurosensory retina. And these are the other layers of the retina. Getting a cross section of the eye at the fovea, you have the neural retina, you have the RPE there, then you have the choriocapillaries. So your subretinal space is somewhere in the middle there, and that's where fluid tends to accumulate when you have a retinal detachment. So there's a pull and a traction there. So I just wanted us to also have an idea of the factors that help to maintain retinal apposition. In other words, forces that help to keep the retina together. And looking for that, we actually have, there are three major forces there. We have the hydrostatic pressure, which is said to be higher within the vitreous as a result of the intraocular pressure in the eye. Then you have the oncotic pressure in the choroid, which is usually higher as a result of the substances you have in the choroid compared to that found in the vitreous. Then you also have the retinal pigment epithelium pump that is said to actively transport solutes and fluid from the subretinal space into the choroid. So that's also one major thing that prevents accumulation of fluids or whatever you have in the subretinal space. It tries to keep that space dry at all times. Whenever there's a problem, you can actually have when you have a problem, there will be the ability to transport solutes and fluids will be defeated, and so you can have accumulation of fluids there. And some people also see that the adhesions of the interphotoreceptors around the rods and cones of the photoreceptors are also contributory to maintaining retinal apposition. But then the factors that will now promote passage of fluid or cause a break into the subretinal space or cause a force of detachment will be vitreoretinal traction, which can be dynamic, which can occur by rapid eye movement, or the vitreoretinal traction can be the static one when you have some vitreoretinal interaction from maybe proliferation in the vitreous where you have membranes being formed and then they now exert traction on the retina. Then you also have gravitational forces that can promote the spread of subretinal fluid. That's basically from the effects of gravity. Then I would like us to look at some of the precursors to rhegmatogenous retinal detachment. It's said these precursors said to contribute to about 60% of the chance of having a retinal detachment. A dialysis, a horseshoe tear, a posterior vitreous detachment, lattice degeneration, some of the degenerations I talked about, snail track degeneration, degenerative retinoschisis, diffuse retinal atrophy, white without pressure and white with pressure. So for the etiopathogenesis of rhegmatogenous retinal detachment, I try to look at it in this way. When you have a dynamic vitreoretinal traction with a posterior vitreous detachment, we all know that as vitreous becomes more syneretic with age, a posterior vitreous detachment can occur. And in most cases, the vitreous gel will separate from the retina without any sequelae. However, in certain eyes, strong vitreoretinal adhesions are present, and the occurrence of the posterior vitreous detachment will lead to retinal tear formation. When the tractional forces at the site of the normal vitreoretinal adhesion exceed the tensile strength of the retina, you can actually have the retinal tear occurring. And if the tear interrupts a retinal vessel, there'll be retinal hemorrhage, and then sometimes vitreous hemorrhage, like some patients who eventually present with floaters. The turbulent currents which occur with ocular movements may lift the edge of the retinal tear, allowing continuous flow of fluid into subretinal space and subsequently leading to retinal detachment. So this is just a pictorial diagram showing the pathogenesis. Some of the risk factors I had stated there: age, race, myopia, then any patient developing a posterior vitreous detachment from age, then peripheral retinal degenerations like lattice degeneration or snail track degenerations, and the other risk factors, aphakia, trauma, will all predispose one to having a retinal break. And then with the retinal break, you'd see there'll be seeping of or degenerated vitreous fluid through the retinal break into the subretinal space, and then that collects at the subretinal fluid and then causes the retina to detach. For the tractional retinal detachment, I try to look at it this way. Usually you would have fibrovascular membranes over areas of vitreoretinal adhesions whenever you have a tractional retinal detachment about to develop. So the progressive contraction of these fibrovascular membranes over these areas of vitreoretinal adhesions, we will remember that the vitreous is firmly attached to the retina at some particular points at the optic disc, the blood vessels, the ora serrata, that's the vitreous base. So whenever you have progression of vitreovascular membranes over these areas of vitreoretinal adhesion progressively contracting, it can predispose you to having tractional retinal detachment. Again, it said that in patients with tractional retinal detachment, there could be a posterior vitreous detachment, but then for them, the posterior vitreous detachment is usually as a result of leakage of plasma constituents into the vitreous from the fibroblascular network adhering to the cortical vitreous surface. So most times it's not a complete posterior vitreous detachment like you would commonly see in patients that have hematogenous retinal detachment, because there's still strong adhesion of the cortical vitreous to some of the fibrovascular areas. So we can see in this diagram here, we have some of the vitreoretinal tractions that you would see. The tangential one is the one that I actually have around the blood vessels, around the arterial arcade, while the anterior posterior vitreoretinal tractions are the ones that extend from the posterior part of the retina over up to the anterior part, very close to the ora serrata, if not even anterior to it. So sometimes the progressive interaction between these vitreoretinal tractions, like we have here, we have the tangential interacting with the anterior posterior. So it's giving us a bridging kind of contraction. So with this, there's some exertion on the retina. So you can actually pull the neurosensory retina away from the RPE. Then I have a pictorial diagram for the pathogenesis of exudative retinal detachment, where basically here what happens is that the retinal pigment epithelium pump fails, and so from the ciliocoroidal effusion, that the vessels or the pathology in the choroid, you have seeping out of fluid. And then because the retinal pigment epithelium is not able to actually transport this out of the subretinal space, there's some accumulation and it can lead to a detachment of the retina. So just looking at some of the clinical presentations that patients with retinal detachment will present, I lumped them together, but the presentations are actually different for the different people. But as we go now, I'll try to differentiate. So most commonly, they'll come in with a history of black cotton defect. That's a history of visual field defects. Once the subretinal fluid has extended posterior to the equator, so they tell you that they feel as if there's a veil or something trying to cover their vision. But it's important to ask the direction of the quadrant that it was first noticed, because that can actually aid you in locating the break. It said that the break is usually in the direction, it's opposite the direction of the quadrant in which the visual field defect is first noticed. Then it's also good to ask if the visual field defect varies with head position. It's known that in exudative retinal detachment, where you have the subretinal fluid shifting, if they lie down, the subretinal fluid gravitates to the most dependent part. So they may tell you that the cotton defect varies with the visual field defect. Then again, in some of them that will come with the history of the black cotton defect, they'll tell you that they notice it towards as the day progresses, because usually when they lie down in some patients, there's reabsorption of the subretinal fluid. But by the time they wake up, the pump begins to fail. And then, sorry, because of the effect of gravity again, that is when it becomes more noticeable. So it's also important to find out the time of the day in which the first notice it. Then some will come with a history of floaters, and the floaters could be from in the rhegmatogenous retinal detachment. It could be from a tear, if the tear affects a vessel. It could be from hemorrhage. Then it could also be from condensation, because some of them that have posterior vitreous detachment will have a condensation of the collagen fiber. So some of them will actually tell you that they're seeing floaters. Then there's a history of photopsia, which is usually more noticeable in dim illumination. Then some of them will come with a history of sudden or painless deterioration of vision. If the macula, the detachment has already affected the macula, it will give a sudden painless deterioration of vision. Or it could actually be a gradual but painless deterioration of vision, like you would actually see in tractional retinal detachment. Then the other symptoms, ocular symptoms of underlying systemic disease may be present, like for the rhegmatogenous retinal detachment, who usually would have some mild anterior form of uveitis. There may be history of redness or photophobia. Then based on the etiology of the retinal detachment, you could actually have other ocular symptoms. Then it's good to find out if there's history of any trauma, whether recent or in the past days. Then it's good to find out the history of spectacle use or refractive error. That helps you to rule in myopia, which you all know is a risk factor. Then history of past ocular surgeries or procedures is very important, especially your cataract surgery. If it was a complicated surgery, if there was a posterior capsular rent with vitreous loss, you know that could have predisposed the patient to having the detachment. Any refractive surgeries gives you an idea that the patient probably is myopic. And then the patient has had laser treatment is also a risk factor. So your history covering this will give you an idea of what is actually happening. Then it's also good to find out if there's history of prior retinal detachment. Has the patient had a retinal detachment in the other eye? Then any previous eye disease or inflammation. We all know that for the exudative form of retinal detachment, inflammatory conditions like Vogue-Kyanada, Harada disease can actually predispose them to having retinal detachment. So it's good to actually find out the history and document that. Then the past medical history of the medical conditions like diabetes, which can predispose them to having tractional retinal detachment, sickle cell disease, which will predispose them to having the same tractional retinal detachment, hypertension, systemic conditions with risk factors, systemic conditions like Stickler's, Ehlers-Danlos, all the connective tissue disorders actually would also pose a risk to developing retinal detachment. So it's important to find out that. Then the family history of retinal detachment is important too, because it can predispose one to having retinal detachment. So a quick look at the examination. I'd like to do a general physical examination because most of these patients may end up in the theater. So it's good to do a general physical examination, paying attention to all you will do, the cardiovascular system, if hypertensive, from toxemia of pregnancy, the respiratory system, just to be sure there are no risk if patient is going to end up having a general anesthesia. And for the ocular examination, while I do the visual acuity is actually the first I should do. But before then, just a quick, the external signs of ocular trauma could actually come under general physical examination. If there's any obvious scar anywhere close to the eye, I would note that. Then the visual acuity could be normal, it could be normal or reduced depending on the location of the retinal detachment, the level of subretinal fluid, and macular involvement. If the macula is not involved, most times the visual acuity could be normal or reduced, but most times when the macula is involved, or the subretinal fluid is the bullous one overlapping the macula, the patients will complain of reduced vision. Just to state that a very careful retinal examination preoperatively and then intra-op is very important when you're working up a patient for retinal detachment surgery. Then in the clinic, using my slit lamp with a contact lens, a non-contact lens, I'd like to do a quick slit lamp examination. Like I said, paying attention to external signs of ocular trauma, maybe at the lids, if there are any scars, conjunctiva, it may be quiet or then maybe mildly inflamed. But then particular note here, you could have some mild anterior uveitis, especially in the tractional retinal detachment. In the regmatogenous retinal detachment, so I may see a few cells and flare in the EC. Then the pupil, there may be relative afferent pupillary defect, especially if the retinal detachment is extensive. Then in the lens, depending on the state, it may be, the patient may be a phakic, there may be an IOL present, or maybe a clear lens, or there may be some early lens opacity. Then for the vitreous, basically you would actually see tobacco dust in the anterior vitreous. That's the Schaffer's sign, some pigmented sign and pigmented cells. There could also be blood in the anterior vitreous, and then there could also be posterior vitreous detachment if you're able to look carefully close to the optic disc. Then if I check the intraocular pressures and I compare to the normal eye, it will be found to be lower by about 5 millimeters. So for the fundal examination, which is very important here, it's good to know that the signs will depend on the duration of the retinal detachment and the presence or absence of a proliferative vitreoretinal retinopathy. So what I'm expected to do here is a dilated examination using the binocular indirect ophthalmoscopy with scleral indentation, so as to allow me to see up to the ora serrata, the extreme periphery. And then I'll have to do a fundal diagram to be able to show the locations of the bricks to assist me when I go into the theater. So it's also good to know the distribution of breaks. Even before examining the patient, I should have an idea of the general distribution of breaks. He said that 60% are located superior-temporally, 15 superior-nasally, 15 inferior-temporally, and then 10% inferior-nasally. So for the fresh retinal detachment, fresh regmatogenous retinal detachment, the features I would see on the retina will be a convex-shaped subretinal a convex-shaped retinal detachment that would appear slightly opaque and corrugated from the edema, and then that would have accumulated in the retina. And then because of the push, the pull of the neurosensory retina from the RPE, it appears slightly raised. And so it's opaque and corrugated. I may see a retinal break, and usually the horseshoe or flap is one that is guilty most times. And the retinal vessels appear darker because there's loss of underlying choroid. The distance between the two has pushed it away, so it appears darker. And then it will undulate freely with eye movement, and then there won't be any shifting fluid. For the tractional retinal detachment, the configuration is really concave. It has stout surface. There's no shifting fluid, and then it does not move freely with the eye. Usually you would not find breaks in tractional retinal detachment, and then the extent of subretinal fluid here is usually shallower and rarely extends to the ora serrata. For the exudative, the configuration is convex, the surface is smooth. The mobility, it has a shifting fluid, so it tends to move as the patient changes position. There are usually no breaks, and then you actually would see an underlying cause when you do a proper examination. There may be a tumor in the choroid. Or you may also see some other tail signs, like if there's hypertensive retinopathy, you could pick attenuated vessels or edema of the disc. Then the leopard spots actually are seen in exudative retinal detachment when the detachment has actually resolved. Then in long-standing cases of regmatogenous retinal detachment, what you see mainly is retinal thinning. You see the secondary, you can see secondary intraretinal cysts and subretinal demarcation lines. So these are just the pictures to actually show what I've been talking about. This is actually, the first one here is actually a regmatogenous retinal detachment where you have but this is a corrugated convex subretinal fluid. you can see that it is opaque because there's some retinal edema occurring, and the vessels are not as distinct as you see on this other side because the retina has been pulled away from the choroid. And this is also another good diagram of the rhegmatogenous retinal detachment. Okay, again, occurring, if you remember the distribution of the bricks, we have a corrugation here, convex shape. Then here the vessels appear distinct, but ideally they should. This is a diagram, so I don't know if it's using the vessels will actually be good. And this is a tractional retinal detachment picture where you have the fibrovascular membranes, as you can see here. And then some areas of retinal hemorrhage. Then for this, you have the exudative and then the convex shaped convex shapes of retinal, convex shaped the convex shaped appearance of the detachment. Then this is the exudative retinal detachment. We can actually see over here is the choroidal melanoma. Then we have a subretinal fluid here in form of, it's a bolus-shaped subretinal fluid that is convex shaped. And these are other pictures that would show us the complications, or rather the long-standing changes of retinal detachment. The first one here is a retinal cyst, which usually will develop if the retinal detachment is not being attended to. This just shows the scan demonstrating the cyst above there. Then E is actually a demarcation. There's a demarcation line that is surrounding the localized fluid with a small round asymptomatic hole. The hole is supposed to be around, the hole is supposed to be around here. I'm not sure where the demarcation line is here, but then this is a clear demarcation line here. We can see the healthy retina and the detached retina. So with time, if nothing was done to the retinal detachment, pigments begin, the RP proliferation, you begin to have deposition of pigments in the RP layer, and then you have the demarcation line. This is just another diagram showing the intraretinal cyst that would occur as a result of rhegmatogenous retinal detachment. Then this is just the leopard spot I talked about in exudative. Once the subretinal fluid has cleared, you have leopard spots, some diffuse clumps of pigment in the retina. Then some differential diagnosis of rhegmatogenous actually would be acquired retinoschisis, in which they present with splitting in the interlimiting membrane. Usually there are no symptoms. The contour of the detachment is smooth and it occurs in inner layers of the retina. And if the patient has a choroidal detachment, they may come in with some of the history, they may come in with a history of sudden painless loss of vision, but then their RAP will be very, very low. They may still have floaters and floaters, and then if you do your binocular indirect ophthalmoscopy, you actually see a smooth brown elevation anterior to the vortex vein. For solid retinal detachment, you can actually, when they come in with a history, your history is actually more streamlined to the cause of the retinal detachment, the choroidal tumor, and then probably a cyst too. And the investigations, he said that the diagnosis of retinal detachment is mainly clinical, but lab testing may be indicated in tractional or exudative retinal detachment, especially if the cause cannot be determined from the history. So there are specific investigations I could do. I could actually do a quick visual field assessment, a confrontation test right there in front of the presence. You would actually notice the gross visual field defect depending on the visual acuity and then the area where you have the detachment. And OCT will actually show separation of the neurosensory retina and the RPE. It would also show if the foveal is attached or detached. Then it could also give us an idea of where the subretinal fluid is coming from. The OCT would actually help to identify tractional membranes in tractional retinal detachment. And then the PVD may also be obvious on the scan. If I do a B scan for a rhegmatogenous retinal detachment, I would actually see a highly reflective irregular convex membrane that moves freely with eye movement. But for the tractional retinal detachment, the reflective membrane is tented into the vitreous. It's not really mobile like you would see it in the rhegmatogenous retinal detachment. And then an A scan for any of this, especially for the rhegmatogenous retinal detachment, will give me a singly highly reflected spike. And then the A scan also would help to actually measure the AP diameter, and that could actually, if I did not get a history of myopia, that may actually, or I had the history of myopia and I was not sure of the power, it could actually help me. And an ERG done, electroretinogram, will actually give a reduced B wave, telling me that the retina has been affected. It may not really give the exact detachment that has occurred, but it just gives an idea that a detachment has occurred, and that's why you have a reduction in the amplitude of the B wave. These are just diagrams again showing what I just talked about. This is a posterior vitreous detachment. You can actually see the vitreous has detached from the optic disc, which is one of its strong adhesions, and you have the detachments floating in the vitreous as a result of syneresis and synchisis. Then for retinal detachment, this is a classical one most of us see in clinic, where you have the funnel-shaped detachment. Here, the detachment is still attached. You have the retinal is detached, but then the attachment is still at the optic disc. You still have the attachment because that's one of the places where you still have you have one of the strong forces. So you have the V funnel-shaped detachment, and this is still something similar. This just shows that there's subretinal fluid here, just like you would have there. Then there are areas of vitreous traction here. You have a detached retina here. And this is the OCT here that would actually show this subretinal fluid accumulating between the RP and the neurosensory retina. And we can see here that it's macula involving. So the macula has been detached. This is still another picture showing the same, another OCT showing a retinal detachment. And for cases of exudative retinal detachment, a fundal fluorescein angiography would actually demonstrate leakage or pooling and help to identify the subretinal fluid in cases where you have systemic conditions causing, or even ocular conditions causing exudative retinal detachment. And some of the ancillary investigations I'd like to do, because I may need to intervene surgically, I'll need to do a full blood count just to be sure that the hemoglobin level is adequate. I'd like to look at and there's no infection from the white blood cell count. The platelets, if they are adequate, and then then erythrocyte segmentation rates. Some of the conditions that can cause exudative actually will give rise to a high erythrocyte segmentation rate. So I'd like to watch out for that. Then a clotting profile, I'm going to subject my patient to surgery. So I'd like to look at what the clotting profile is all about. And the genotype, sickle cell disease is one of the causes of tractional retinal detachment. So I'd like to either confirm or rule that out. Then electrolytes and creatinine just to assess the renal status of this patient, because I'm taking him or her to theater. Then a fasting blood sugar to rule out diabetes or to see how well controlled it is, knowing that diabetes is one of the causes of tractional detachment. So for the treatment actually, I looked at it in 2 ways: retinal detachment surgeries, treating the underlying cause, especially for exudative retinal detachment, and then offering prophylaxis treatment. So just to look at the principles of a retinal detachment surgery, one is expected to find all the retinal bricks, and that I can do by using an indirect ophthalmoscopy with scleral indentation, like I earlier said, to help me see the periphery up to the oral serrata. And then I'll use the Lincoln's rule to guide me, so I have an idea where the brick is. Then secondly, I would seal all the retinal bricks, either using cryo, PEGC, or laser photocoagulation. And the aim is just to create a controlled injury to the RPE and retina. That's to produce a coretinal adhesion around the bricks, around each brick, to prevent further seepage of fluid into the subretinal fluid. Then I'll drain the subretinal fluid if necessary, because it's not in all cases I have to drain. And I'll now relieve vitreoretinal traction by bringing the retinal brick to the underlying treated RPE either using a pneumatic retinopexy, scleral buckle, or a vitrectomy. So the goals of surgery for RD, mainly to preserve or restore vision, especially if it involves the macula. It says the macular function is given the higher priority and the function of the peripheral retina may be sacrificed if required. Then there are preoperative considerations that would need to bear in mind. Knowing that the choice of treatment for any retinal detachment depends on the type, the size of detachment, whether it involves the macula, the configuration of detachment, the location, number, size of brick, phakic status of the eye. As we go on, we'll see the different surgeries and their indications. And also the type of surgery offered depends on the surgeon, how skillful he is in any of the surgery techniques available. But it said that now most surgeons, retinal surgeons, are becoming more familiar and there's more confidence among them now. So, but then while I am trying to work up this patient for surgery, there are some that would require urgent surgery. And these actually are the acutely symptomatic retinal detachment, those with superior brick or a large brick, those with high myopia that have advanced syneresis, and then those with fresh dense vitreous hemorrhage with underlying retinal detachment. Then as I walk my patient up to having surgery, some of the general treatment measures will be to actually put them off food or water in anticipation of the surgery. I'll try to limit activity to a minimum, and then I'll ensure that the head is turned so that the retinal brick is in the most dependent position. Then if there are any unstable vital signs, I'd like to look at that. Then going back to the principles of surgery, the first, as we all know, which was to identify the bricks using your Linkoff's rule. I have four rules, which are really the main major rules from which the modern Kansky has revised some of these rules and brought out 6, but this is from this same 4 major Linkoff's rule that you actually would draw your fundal diagram and identify your brick. So for the lateral retinal detachment here, there's an inferior retinal detachment. It's a retinal fluid higher on one side of the disc. So you can see this is a subretinal fluid here that is higher on one side of the disc. And it said that the break is at 1.5 clock hours from the higher side. So if you have a subretinal fluid on one side of the disc and the one portion of it is higher on one side, the best place to look for your break will be at 1.5 clock hours from the higher side of the detachment. Then for the second rule, if there's a superior retinal detachment, like we would see here, you will see here that the subretinal fluid has crossed the vertical midline above the optic disc here. So the break in this case is superior here within a triangle. So if I draw a triangle with the apex of the triangle at 12 o'clock, with its apex at 12 o'clock at the ora serrata and the base 11 and 1 o'clock, my break will be within that triangle. So I have to draw a triangle this way. So the break, which is the retinal break there, is said to be within that triangle there for a superior retinal detachment. Then for the inferior retinal detachment, if there's an inferior retinal detachment and you have equal subretinal fluid on both sides of the disc, as we see in this first diagram, the break is usually inferior and it's said to be usually at 6 o'clock position. That's where to look for your break. Or you can actually, if the subretinal fluid is not equal and it's a little higher on one side, then the break will be inferior but closer to the higher border. So this is one of the modifications in the new Kansky. So this has actually been taken out, and then this, so you have 2 from this inferior here. Then for the last rule for Linkoff's, for detecting your retinal break, if there's an inferior bullous retinal detachment, like we can see here, the break is said to be on the higher side of the retinal detachment. So for this and this, this is actually higher compared to this. So the retinal, the break actually is on the higher side, which is why it's a little close to the higher side here, and it's above the horizontal meridian. And you can see that there's some subretinal fluid tracking inferiorly. So if you look at the new Kansky, this actually has been modified. They splitted the inferior bullous detachment, localizing the break to be superiorly close to the retinal, close to the area of higher bullous, close to the area where you have a higher subretinal fluid. And then they have another one where you still have your bullous detachment, and then you have the subretinal fluid tracking inferiorly, and then you still have the break located inferiorly on the higher side of the retinal detachment. Then the other step, the next step after identifying your break, you're supposed to do a subretinal fluid drainage, but they said it's not always an essential part of the retinal detachment, because in most cases, the subretinal fluid will absorb spontaneously when you adequately support and seal your break. So it's not something that is always done. And some of the indications for having to do this subretinal fluid drainage could actually be either the retinal detachment related or patient related. If there's an immobile retina, as in proliferative vitreoretinal retinopathy, if there's a long-standing retinal detachment in which the subretinal fluid is viscid, if there's an inferior break from effects of gravity, so it's difficult to actually localize your break. If you have a bullous detachment, you're unable to oppose the retina for adequate retinopexy. If you have difficulty localizing the retinal break, so if you have a proliferative vitreoretinal membrane that's greater than grade B, there are indications for having a subretinal fluid drainage. Then also, if the patient is a high myope, if there's a poor retinal pigment epithelial function, especially in elderly, if there's pre-existing glaucoma, recent cataract surgery, or you think clearer, you can actually do a subretinal fluid drainage. Then the advantages are that when you drain, it actually provides immediate contact between the RPE and sensory retina. So you're able to have a good adhesion or a good contact after the detachment is done. But if you delay it, it said that you will not get adequate reattachment of the retina. Then there are some sites, when you want to do a subretinal fluid drainage, there are some sites which you should aim for. You should go for the most bullous area. You should go above or below the horizontal meridian in a bid to trying to avoid the vortex veins there. Then usually between the aura and the equator is a good place to go. Then temporal retina, because you have more actors when you're coming temporally, and then away from the break. And then also, if you have a scleral implant in place, like when you're doing this together with the scleral buckle, usually in the bed of the scleral implants would be better for you to drain. So just to run through the procedure of how to go about a subretinal fluid drainage, you need to choose your site of drainage. Like I said, any of the areas I just listed, and then you catheterize. You perform a radial sclerotomy until you can actually see your choroid clearly. Then you try to catheterize the lips of the incision you've made. And then you can now place your 5-ovicryl mattress sutures to the lips of the sclerotomy. Then you actually try and prolapse your choroidal knuckle while you examine with the 20D for any obvious large choroidal vessels. You then use either a 27G or a 25 needle, or you can use your endo laser to actually puncture that choroidal knuckle, which you try to prolapse. And then, but you go at an oblique angle. And then once you do that, you actually notice the subretinal fluid draining, but you need to control it so that you don't cause an obvious ocular hypotony. So you can use your cotton tips or the fingers to actually control the amount of subretinal fluid that is coming out. If it's viscid, that's long-standing subretinal fluid, you may have to milk it out. So while you do that, you need to check for hypotony or flattening of the retinas. You may need to inject air or saline to prevent a choroidal detachment. You then suture your incision that was made with 5-ovicryl sutures. So here we can actually see a picture of a subretinal fluid drainage that is being done under a scleral buckle. This is scleral buckle. So this is the radial sclerotomy that was made obliquely, and then they're using the cutting board here to try and gently control the amount that is coming out. And then I don't know if it's VC, but if it was VC, they would actually gently milk it out. Then it said that, okay, sorry, this is not supposed to be here, but some of the complications of draining subretinal fluid could be choroidal hemorrhage, ocular hypotony, iatrogenic break, retinal incarceration, vitreous prolapse. Then you could also have damage to the posterior ciliary arteries and nerves, and then the posterior post-operative endophthalmitis. Just to mention here that most of these techniques are actually done together. It's not one thing. That's why you can actually see a diagram of the scleral buckling done there, and then there's actually subretinal fluid drainage done there, and then also a pneumatic retinopathy where you have to inject a gas after you have drained in case you have a flat retina. The pneumatic retinopathy is another method in which an intravitreal gas bubble together with cryotherapy or laser is used to seal the retinal break and reattach the retina without scleral buckling. The principles: there's intravitreal injection of an expansile volume of gas, about 100% concentration, to seal the retinal break based on the following properties. Mechanical closure. The properties which the gas is using to seal the retinal break are actually mechanical closure, surface tension, and buoyancy. So for mechanical closure, it's helping to form an arc of about 90 degrees. The volume of gas, which usually would inject, will form a 90-degree arc of contact between the detached retina. It forms a 90-degree arc of contact, and then will tamponade any break that is usually 1 o'clock hour. Then your surface tension, now there's a diagram to actually show what I'm trying to explain. Then the surface tension of the gas will actually help to close and prevent fluid from passing through the break that is there. And then the buoyancy of the gas is used again, helps to create an upward pressure on the detached retina. But again, like I said, while you inject your gas, before you inject your gas, you need to do your retinopexy to permanently seal the retinal break, while your gas just helps to maintain and augment the sealing while allowing the subretinal fluid to be drained via the RPE pump mechanism. So this is just some of the gases that are commonly used in vitreoretinal surgery. Usually air, which is readily available, is not a good vitreoretinal gas to use because it is rapidly absorbed. So most times, and it does not expand as well. So most times once you inject it, the effect of it staying to help to tamponade the detachment, because it's rapidly reabsorbed, may not really help. But then your sulfur hexafluoride expands by 2 by 2. So if I inject 1.5 mils, I expect it to expand by 2, and it stays for about 1 to 2 weeks. And then the other one commonly used is the perfluorocarbon, and also this the C3F8 gas, which can also expand by 4 and has a duration of 6 to 8 weeks. The expanding gases, if actually the aim is to use them non-expansor, like in your vitrectomy, past plantar vitrectomy, where your aim is just to form the vitreous, to form the posterior segment of the eye after doing a vitrectomy, you can actually mix with air. But then the problem with using expanding gas is that the patient must be taught to maintain a predetermined head posture to place the breath in the least dependent part. And other tamponading agents, we can also be used at the silicone oils. They are said to have a low specific gravity. They're higher than water, so they allow the subretinal fluid to drain through the peripheral retinal break. And then you can use them for some other intraocular retinal manipulation. And they also have a long-lasting intraocular tamponade effect. Then heavy oils, that's the perfluorocarbons, are also used because they actually would help they have high specific gravity, good optical clarity, and low viscosity. So these are some of the substitutes you can actually use when you're doing a vitrectomy after you have done your past plantar vitrectomy, and maybe to reform your posterior segment. Then to describe the pneumatic retinopexy, you take your consent for the patient, you explain to them it's a minor procedure. Some people do it as outpatient, but then they may need to understand that they have to have a good posturing, and there may be a need for a repeat procedure. You dilate the eye maximally, you examine the eye. Even if it has been done in the clinic, you need to examine again in the theater to be sure you've localized your break. Then after your retrobulbar anesthesia, the area around the break is treated with cryotherapy. Then you try to soften the eye by using your Horner's balloon or any other thing that is available. You observe strict asepsis using your povidone iodine. And using your 30G needle, you go 4 millimeters posterior to the limbus. Avoid that in patients that are phakic. And then you inject 0.3 mils of the choice of gas you're using. Usually we use pure filtered carbon, perfluorocarbon, or you can use 0.6 mils of sulfur hexafluoride. But then it said that when you're injecting, you should try to inject to the highest point of the eye through the uvea, as in use just try and inject only one bubble, because if you don't do that, you're going to end up with fish eggs. And then while you're doing that, because of the pressure that is being transmitted, you need to watch out for the central retinal artery perfusion. And then if there's a need for paracentesis, you may need to do so to reduce the intraocular pressure. While that is done, you need to do your retinopexy using either laser, indirect ophthalmoscopy after you've injected your gas. But it said that the gas rarely interferes with the delivery of your laser within the retina, and the diode pumped green lasers are preferred. The patient is then allowed, the head of the patient is then positioned so that the bubble is in contact with the break. And the patient is allowed to keep his head that way 16 hours per day for at least 5 days. And then at night, the patient can actually sleep on his or her side. You place the patient to a mild topical steroid and antibiotics 4 times per day for 1 week as a post-therapy. This is a picture of the gas bubble being injected as a single bubble. Then because of the expansile nature of the gas, it expands and then it floats upwards because it has a low specific gravity. So it has gone to tamponade the retinal tear you have there. Then depending on the gas that is being used, with time, the gas shrinks and then you have, but then by the time it has shrunk, it's shrunken because of the contact between the gas and the retinal tear. The retinal tear would have healed, and so you would have achieved the complete closure of your retinal tear. This is also another picture here. So for this case, we can actually see that cryopegs is actually done to actually create some kind of retinal adhesion. This is the tip of the cryo probe that is being used. And then the air bubble is injected. When injected, this is what you actually would have. Then with time, you actually see that it has been reabsorbed. The gas has been reabsorbed, and you have created the retinal tear there would have healed. This picture here is just showing us the fish eggs. When you inject the bubble, when you do not inject the bubble as one, it comes out this way. It looks like fish, the eggs of a fish. But sometimes the gas bubble itself may break up when in the vitreous, and it appears as this. This is just a diagram showing the retina here. A gas bubble was injected, but then it has been reabsorbed. And so you have a flat retina. And some of the indications of a pneumatic retinopexia: single retinal breaks, or if you have small groups of breaks confined to 1 clock hour located in the superior 8 o'clock hour of the fundus. If there's a clear media, you can actually do pneumatic retinopexy. If you have a patient who will maintain proper positioning, then if there's any contraindication to general anesthesia for scleral buckling, you can actually offer pneumatic retinopexy. Some contraindications: if the media is hazy, you may not be able to see. If the patient is not able to maintain the head posture or has glaucoma or proliferative vitreoretinopathy grade C and D, there are contraindications. And some of the complications you could actually have, you could have a corneal endothelial decompensation, band keratopathy, shallow anterior chamber, papillary block glaucoma, lens opacity, central retinal artery occlusion from the raised intraocular pressure. There could be subretinal gas migration, anterior chamber gas migration, recurrent retinal detachment from formation of new retinal detachment, and endophthalmitis if you inject a contaminated gas. Then scleral buckling is another technique, surgical technique that is offered to patients that have retinal detachment. And here what you actually aim to do is to seal the retinal bricks by indenting the sclera with an external appliance. Indenting the sclera forms a buckle, while the external appliance we're using is actually the explant. The buckling will actually cause closer position of the retinal brick to the RPE by moving the retina close to the posterior vitreous cortex. This reduces or eliminates traction on the retinal bricks and other areas of local vitreoretinal adhesion. There are different types of explants that are used depending on the retinal brick you have. There's a radial explant, which is usually placed right angle to the limbus. There's a segmental circumferential, which is placed circumferential with the limbus to create a circumferential buckle. Then there's the encircling circumferential that takes the entire circumference of the globe. Then these explants are made up of different materials. There's a hydrogel, there's the silicone, but then the hydrogel is actually not in common use. Most the ones in common use are now the silicones. And for the silicone, you have the soft and the hard, and you have the sponge, the straps, and the tires. The soft silicone sponge are used mainly for radial and circumferential buckling. The hard silicone straps mainly for 360 degrees buckling. And then the hard silicone tires, you can use that to supplement if you're doing an encircling buckle. And then when you're applying any buckle, it should actually be of the buckle you create from your external, from your explant should actually be of adequate length, height, and width. And it said that most times, most local buckles will lose their effect after 3 months. So hoping that within these 3 months, the retinal tear would have healed and the retina would have been reattached. So that even if the permanence is no longer there, you would have achieved your purpose. Some of the indications for offering a patient scleral buckling are when you have a simple rhegmatogenous retinal detachment and if there's a dialysis and there's no posterior vitreoretinal detachment. Then if for the radial buckling, it's commonly used when you have large U-shaped tears, especially when you're anticipating fish mounting. Fish mount is actually when you have a large U-shaped tear, a large U-shaped tear occurring when you're trying to actually buckle, you're trying to seal up a U-shaped tear, you actually have another U-shaped tear occurring as a result of the buckle you're trying to apply. Then the radial buckling can also be used for posterior bricks. Then it can also, the segmental or circumferential buckling can be used for anterior bricks. If you have a multiple small medium brick within 1 clock hour, at a varying distance from the oral serrata, you can use it. Then the encircling bands can be used if you have extensive multiple bricks in 3 or more quadrants. It can also be used when you have high-risk features like aphakia or pseudophakia. Then there's extensive retinal detachment. You cannot see the bricks, you can actually use an encircling band. And if there's lattice degeneration in 3 or more quadrants, is also an indication. If you need to do an excessive drainage of subretinal fluid, it's an indication. Then for failed segmental buckle, without any obvious reason, you can actually use your encircling band if the segmental has actually failed before. So this is just a picture. So what the scleral buckling actually does is that it indents the eye wall. So as it indents the eye wall, so this is where we have our tear here. So we're going to apply our explant around here. So when you apply the explant here, when you apply your explant here, it actually causes a buckle. This is the buckle it's going to cause. And then it tries to push away any subretinal fluid, which may be reabsorbed or you may need to actually drain. And then depending on how long it's going to stay, it will help to reattach the retina at this position. So again, when you're choosing where to place your buckle, it's good to place your buckle in such a way that the posterior edge of the brick is on the buckle. This is the posterior edge here. We can actually see the buckle is actually over it. Then ideally it should extend 30 degrees on either side. 30 degrees on either side. Some books say 2 millimeters on either side, and you should extend up to the ora serrata when you're applying it. Then this is just the pictorial diagram showing the configuration of the scleral buckles. This is the radial that is placed at 90 degrees to the limbus. This is the segmental circumferential when you have multiple bricks lined close to each other in about 1 to 3 quadrants. You can actually use this. You can see the multiple bricks there, so you're able to use the segmental circumferential. Then sometimes you may need to augment. Outside using the segmental, you may need to augment with a solid silicone tire, which is what the inner one there is, the tire that is being used to augment the encircling. And these are different silicone, different types of explants you can actually see. These ones are made of silicone, and these are the sponge types. So in this diagram, you can actually see that there's a buckle has been created here. I can't really see the explant here, but a buckle has been created, and then with time, it has healed. And you'd see that that's the area where the retinal tear was initially. Then for the scleral buckle, the procedure is to obtain consent from the patient. You do a conjunctival periotomy at the limbus. You use your squint hooks. You insert them under the erectus muscle. You try to rotate the globe just to be sure there's no restriction. Then you place your traction sutures under the tendon of the rectus muscle using a reverse mounted needle, preferably silk. Then you localize your bricks. And after localizing, you localize the retinal bricks by inserting 5 Dacron suture at the sclera. And this will help you would have localized your break. So inserting this suture is actually just to be sure that you're actually where the break is. Some people say you can use a marker to just mark where the point is. Then you now cut the end of that sclera. You cut the end grasped with a mosquito forceps. Then again, you've localized your break. So you need to identify it using your indirect ophthalmoscopy, and then you indent, then you use your cryo probe to actually create the retinal adhesion around the bricks. This just tells us that the application should last just enough for the retina to whiten. The probe should not be removed until thawing has occurred. Still the same thing. Mark the external position of the brick on the sclera using indentation or a marker. Then before then, you would have had all your explants available. So you select the one you're going to use, and you cover double the width of the retinal tear position so that it extends from the ora serrata to cover the posterior lip of the brick. Then using your partial thickness 5 non-absorbable sutures and a spatulated needle, you actually place your mattress sutures at least 1 millimeter away from the buckle on either side. You tighten the sutures, and then you confirm that the buckle position is correct. You confirm that arterial perfusion of the optic nerve has not been affected. Then you close your conjunctiva with 7 non-absorbable sutures. If there's need to drain subretinal fluid, you drain. The indications I stated earlier, you drain, but if not, you can actually get reabsorbed on its own. You then use your BIU to check if the correct positioning is in place. Then there's something they call the DACE. This is actually done in cases where you actually have an inferior break and you actually cannot visualize the break. So what some people would actually say is that they would actually drain the subretinal fluid and then inject air into the vitreous cavity and then apply your cryotherapy before the scleral buccal explant is actually put in place. Then post-op medications for the patient, you place on systemic or topical antibiotics, Diamox because of the risk of raised intraocular pressure, cycloplegics, topical steroids, and then anti-inflammatory agents. And it's advisable to check the IOP later in the day because of the risk of intraocular pressure rise. This is actually just diagrammatic explanations of what I was trying to say. Here we can actually see that they're trying to pass the squint hook underneath the tendon of the muscle. So after doing that, here they're just rotating the globe to be sure that there's no restriction. And then here, you can actually see a mark. Some point has been marked there, localizing the break after your binocular indirect ophthalmoscopy has been done, so that you're going to apply your buckle at the right place. And then you can actually see the buckle there being implanted after the sclerostomy is done. And then we can see the sutures that are being placed over the explant, at least 2 millimeters away. I can't see the break here, but it's said to be two millimeters away from the edge of the break, and then avoiding the vortex veins when you're draining. Then the complications of subretinal, of scleral buckling, they're intraoperative, postoperative complications, as I've stated on the slide there. And there are also late complications. Then for past plantar vitrectomy, which is what is commonly used now because most surgeons are becoming more competent. It's said to be an intraocular microsurgical procedure that involves inserting instruments to very small incisions in the pars plana into the vitreous to remove dynamic tractional forces from the vitreous, as well as static tractional forces from membranes and fibrovascular proliferation. Currently, you have the 23G and 25 and 27G systems gaining popularity over the old 20G. So it's becoming a sutureless surgery, which you actually will not need to suture since the incisions created are usually very small. And it said that this can actually be done together with a scleral buckle. Remember, I actually said most of these surgeries can be done together. It's not just that you can do more than one procedure on a patient depending on what you actually see. So some of the indications for pars plana vitrectomy, there's a tractional retinal detachment that is threatening or involving the macula. In some selected or complicated cases of rhegmatogenous retinal detachment, where you have giant retinal tears, large posterior breaks, multiple breaks in different meridians, you cannot identify a break. If you have a retinal detachment and the media is hazy, like from vitreous hemorrhage, there's an intraocular foreign body or proliferative vitreoretinopathy. If there's retinal detachment in an aphakic or pseudophakic patient or a high myope, you actually would want to offer them pars plana vitrectomy. And then if you have combined tractional rhegmatogenous retinal detachment, it's a good time to offer the patient pars plana vitrectomy. And your goal of surgery is actually to separate the posterior hyaloid from the retinal surface. You try to remove the periretinal tissue as much as possible so you can release the central and peripheral retinal traction, which is causing the detachment. And then you close retinal breaks if present and if you can see any of them. So some of the instruments we actually use are the vitreous cutter. You have an illumination system, you have an infusion cannula, you have a wide angle viewing system, and you have the accessory instruments, which are the scissors, the forceps, flute needle, endodiathermy, and endolaser delivery system. Then this is just a picture showing the light source. You have a light source, which we would see eventually, usually at about 10 o'clock. You have the vitreous cutter, which usually will be positioned at the 2 o'clock position. And then you have your infusion line, which would actually go inferior temporally. So you also take a consent from the patient, then insert your 3 entry site sleeve cannulas. Like I said, 4 millimeters for the patient who is aphakic, avoiding the lens, and then 3.5 millimeters for an aphakic or a pseudophakic patient. So like I said, inferior-temporally, that's where you have your infusion line. Superior-temporally is where you have the vitreous cutter. Then superior nasally, 2 o'clock, is where you have the fiber optic light source. You secure the infusion cannula to the inferior temporal cannula. Okay, that's just what I'm saying. The infusion is used to maintain the globe, so permitting aspiration, and can be used to increase pressure if intraocular bleeding occurs. That's the main use of the infusion cannula located inferior temporally. Then the light pipe and the vitrectomy are actually the 2 superior portions. But what you're doing is you're actually visualizing under your indirect microscope system using your inverter. Then what you actually do here is just you try to create a posterior vitreous detachment, and then ensure that you carefully shave the peripheral cortical vitreous away from the vitreous base so that you can relieve traction on that area, knowing that it's one of the areas where you have firm adhesions. Some of the surgical techniques used are actually delamination, segmentation, and en bloc dissection. Most times it's said that for vitrectomy, even though it's the same procedure, but what you actually meet is what actually determines which of the methods you actually use. So for your delamination, you're just using a horizontal dissecting scissors to actually see if you can excise the vascular pegs carefully. Then for segmentation, if the delamination, if your horizontal scissors isn't able to do that, you use your vertical scissors. You try and cut the fibrovascular membranes. You try to cut them into segments to allow you dissect evenly. But then if that is also not possible, you can gently try to peel the epiretinal membrane away. And one other thing that can actually help you when you're doing a vitrectomy, you can actually inject your triamcinolone or your trypan blue to actually identify, to actually stain the vitreous so that you're careful and you know exactly what you're doing. And at this point, if there's need to drain the subretinal fluid, you can actually do that. So you create an intentional drainage retinotomy to help you drain the subretinal fluid if you think it will not reabsorb on its own. And then if the proliferative vitreoretinal membrane is present, like I said earlier, you gently try to peel it, and you do that carefully. Then if you notice the retina is flattened, that is the time to apply your laser or your cryoprobe, whichever one that is available. And then because you're trying to remove almost most of the vitreous, what is in the vitreous, you will need to replace with the tamponading agent. Like I said earlier, it could be gas, it could be oil, it could be the hydroperfluorocarbons. Then you remove your cannula, but because the port of entry is very small, using the newer methods, you may not really need to suture. All you need to do is just assess the wound for leak. If you have used intraocular gas, you have advised the patient to posture head down, try to avoid them, try and warn them against air travel, and then till the gas is absorbed so that there's no expansion of the gas when they travel. So this is just pictures showing the lamination and the segmentation. So for the delamination, you're doing it, it's a horizontal thing. So you try to horizontally cut the vascular membranes as much as you can. So that's what is being done here. Then for segmentation, it's more of a vertical thing, and it's done in segments. So it's still the same cutting, but it's said to be done vertically. And then after cutting, you can actually, like here, they've cut and you have it in different bits. So it will be easier to now peel the mask. So these are some of the complications of vitrectomy. It could be intra or post-operative. So the intra-op, you can actually miss the break, or while you're actually doing the surgical procedure, you can actually cause another retinal tear, and then you have a detachment. You can inadvertently touch the lens, then you have a cataract from, okay, yes, inadvertently touch the lens may become opaque. There could be retention of subretinal perfluorocarbon. Instead of the perfluorocarbon, okay, you can have it retained. Then you can have a retinal and vitreous incarceration at your points of entry into the vitreous. You can actually have some retinal vitreous incarcerating there. You can provoke a hemorrhage, that's suprachoroidal or vitreous, and then you can have subretinal infusion. Then some of the post-op complications are nucleosclerotic cataract. Patient can end up with glaucoma. If you use any of the oil, there could be pupillary block glaucoma. If you use silicone oil, it can also be retinal tears. You can have a detachment, recurrent vitreous hemorrhage. You can have massive fibrine exudation, anterior segment neovascularization, the retinal phototoxicity from the light source, which is being shown onto the retina, can actually cause damage some of the RPE cells. And then patient can end up with endophthalmitis. Then because some silicone oil is one of the tamponading agents you can use, the patient can have a band keratopathy, end up with filamentary keratitis, glaucoma, cataract. It can emulsify. The oil can emulsify. That's one of the pathways to the glaucoma. It damages the trabecular mesh, causes emulsification too. Then there could be uveitis, subretinal seepage, subconjunctival cyst formation, ptosis bulbi. And for follow-up of these patients, it's advised that generally, regardless of the method that is used, that you examine them first day post-op, 1 week post-op, then 2 to 3 months afterwards, and then every 6 to 12 months. But this is not a hard or fast rule, as the follow-ups would actually depend on what you see at each visit. Then for the cause of untreated RD, the patient has a retinal detachment and is not treated. These are the following can actually happen. It can spontaneously reattach. A proliferative vitreoretinopathy can arise. The retinal atrophy can ensure the patient could end up with uveitis, have a complicated cataract, uveitis iridis, glaucoma, band keratopathy, and the eye can become ptysical. So it's very good and important to always educate our patients, especially if it's occurring in the first eye, that there's a potential risk to the fellow eye. It's said that the risk in patients that have aphakic eyes is about 10 to 15, in aphakics is 25 to 40. And then you also tell them that whenever, especially if it has happened in one eye, whenever they start noticing floaters or photopsia, it's good that they come to the hospital immediately. Usually the prognosis, the surgical outcome of retinal detachment is discussed in 2 ways. At anatomical success, you may have achieved complete reattachment, which is usually possible in about 90% of cases, but then you also look at it in terms of the, the functional success, that's the visual acuity the patient is going to have after the retinal detachment surgery. So the visual prognosis depends on whether the macula is attached at the time of surgery. If the macula was detached, we all know that the photoreceptors will start to degenerate, impairing visual recovery. And it is believed that only 50% of patients will reach a VA of 20 or 50 or better. And in our own environment, where they even tend to present very late, by the time they present, most of the photoreceptors would have undergone degeneration. So even when you try to reattach the final outcome, even though you have a good anatomic success, the functional success may not really be good. Even if the retina is fully reattached, restoration of visual acuity is not guaranteed. And then we know that it said that the chances of restoring good vision decline as patients age. So that's another factor. If you have an elderly patient, even though as you're counseling them, you actually need to let them know. Freeberg has noted that in macular detachment, VA as measured by the potential acuity meter is an excellent predictor of postoperative acuity, perhaps more predictive than the duration of foveal detachment. So this is just for us to know that we have a patient that has an RD with macular involvement. If we're able to check the VA with the potential acuity meter, we'll be able to better advise and counsel the patient irrespective of the duration of foveal detachment. In conclusion, retinal reattachment surgery has improved over the past decades, and there's improved familiarity and confidence among surgeons now. These are my references. Thank you for listening.